Hey, so our group is going to present schizophrenia, a complex and severe mental disorder that affects millions of people worldwide. My contribution to this presentation is going to be the etiology and pathophysiology of this mental disorder. So let's get into it. The etiology of schizophrenia is not fully understood, but is believed to involve a combination of genetic, neurological, environmental, and psychological factors. Next, we'll get into an overview of some of these key factors that are thought to contribute to the development of schizophrenia. Let's start by looking into the genetic predisposition, which means that individuals with a family history of schizophrenia are actually at a higher risk of developing the disorder. Next, we can go to the environmental, social, and psychological factors. Various environmental factors have been implicated in the development of schizophrenia. This includes prenatal and perinatal complications such as maternal infections, malnutrition, or even stress during pregnancy. Exposure to toxins or drugs during critical periods of brain development, and psychosocial stressors such as childhood trauma, urban upbringing, or social isolation can also be contributing factors. While these things may not directly cause schizophrenia, it's good to note that trauma, stress, even dysfunctional family dynamics, they may interact with genetic and neurological vulnerabilities to increase the risk of developing the disorder or exacerbate symptoms in vulnerable individuals. Some other factors to consider are the neurological factors. Abnormalities in brain structure and function have been observed in individuals with schizophrenia. This includes, but it's not limited to alterations in neurotransmitter systems, particularly dopamine, glutamate, and serotonin, as well as changes in the brain volume, cortical thickness, and connectivity between brain regions. Even if there are disruptions in early brain development that could be maybe influenced by both genetic and these environmental factors, this may also contribute to the onset of schizophrenia. So some of these disruptions, what they do is they disrupt the neural circuitry, the synaptic pruning, and the formation of brain networks critical for cognitive and emotional processing. So those are just some of the factors that um, contribute to the etiology of schizophrenia. Next, we're going to talk about the pathophysiology of this mental disorder. The pathophysiology of schizophrenia involves interactions between genetic, neurobiological, and environmental factors, which leads to alterations in brain structure and function. And even though the exact mechanisms aren't fully understood, there have been several key abnormalities identified, starting with neurotransmitter dysfunction. So, imbalances in neurotransmitters, like I mentioned before, particularly dopamine, glutamate, and serotonin, they play a significant role in schizophrenia. Dopamine dysregulation in the mesolimbic pathway is associated with positive symptoms such as hallucinations and delusions, while abnormalities in glutamate transmission, particularly in the prefrontal cortex, are linked to negative and cognitive symptoms. There have also been neuroimaging studies that reveal structural changes in the brains of individuals with schizophrenia. Some of these include reduced gray matter volume, especially in the prefrontal cortex, hippocampus, and thalamus. Um, these, along with some other structural abnormalities, are thought to contribute to cognitive deficits and symptoms of schizophrenia. And it seems that schizophrenia is increasingly viewed as a neurodevelopmental disorder, meaning that these changes in brain development are beginning in utero and continuing through childhood and adolescence. Like I mentioned before in the previous slide, there are factors such as prenatal exposure to certain toxins that may contribute to this. Excuse me. So we also have to consider the immune system dysregulations that contribute to the patho of schizophrenia. Certain immune function abnormalities, including increased levels of pro inflammatory cytokines, have been observed in individuals with schizophrenia. Um, we were talking about the genetic aspect of it. Even though there is no single gene responsible for schizophrenia, genetic factors play a significant role in susceptibility to the disorder. Um, there have been genome-wide association studies that have identified numerous genetic variants associated with schizophrenia. And a lot of these involve neurodevelopment, synaptic function, and neurotransmitter signaling pathways. So these things interact with environmental factors to increase the risk of schizophrenia. Research into the etiology of schizophrenia is ongoing, with efforts focused on understanding the interplay between genetic, neurobiological, and environmental factors in its development. Likewise, the research into the pathophysiology of schizophrenia is also ongoing. This is just trying to find insights into therapeutic targets for the treatment of schizophrenia. As nurses, we are always encouraged, and it's just a big part of our nursing careers, to remain educated, to remain actually vigilant in our education and just having a thirst for knowledge so that we are able to better service this population when our paths happen to cross. So we just want to keep that in mind to always make sure that we're doing something that can contribute also to this research. And if not contributing, at least we are making ourselves aware of what's going on with schizophrenia and how, like I said, we can be of better service to those who are suffering from this mental disorder.
Hi, I'm Colleen, and I'm going to discuss the clinical manifestations and diagnosing in schizophrenia. Schizophrenia spectrum and other psychotic disorders include schizophrenia, other psychotic disorders, and schizotypical personality disorder. They are defined by abnormalities in one of the following 5 areas: delusions, hallucinations, disorganized thinking such as speech, grossly disorganized or abnormal motor behavior, including catatonia, and negative symptoms. Delusions are fixed belief regardless of evidence to the contrary. Their content may include a variety of themes, such as persecutory, referential, somatic, religious, and grandiose. Persecutory delusions believe that one is going to be harmed, harassed, or so forth by an individual, organization, or other group. Referential delusions believe that certain gestures, comments, environmental cues, and so forth are directed at oneself. Grandiose delusions are when an individual believes that he or she has exceptional abilities, wealth, or fame. Erotomanic delusions are when an individual believes falsely that another person is in love with him or her. Nihilistic delusions involve the conviction that a major catastrophe will occur. Somatic delusions focus on preoccupation regarding health and organ function. Delusions are deemed bizarre if they are implausible and not understandable to the same culture peers and do not derive from ordinary life experiences. An example of a bizarre delusion is the belief that an outside force has removed his or her internal organs, replaced them with someone else's organs without leaving any wounds or scars. An example of a non-bizarre delusion is the belief that one is under surveillance by the police despite a lack of convincing evidence. Delusions that express a loss of control over mind or body are generally considered to be bizarre. These include the belief that one's thoughts have been removed by some outside force, that alien thoughts have been put into one's mind, or that one's body or actions are being acted on or manipulated by some outside force. Differentiating between a delusion and a strongly held idea is sometimes difficult to make and depends in part on the degree of conviction with which the belief is held, despite clear or reasonable contradictory evidence regarding its veracity. Now, hallucinations are perception-like experiences that occur without an external stimulus. They're vivid and clear, with the full force and impact of normal perceptions and not under voluntary control. They may occur in any sensory modality, but auditory hallucinations are the most common in schizophrenia and related disorders. Auditory hallucinations are usually experienced as voices, whether familiar or unfamiliar. They are perceived as distinct from the individual's thoughts. The hallucinations must occur in the context of a clear sensorium. Those that occur while falling asleep or waking up are considered to be within the range of normal experience. Hallucinations may be a normal part of religious experience in certain cultural contexts. Now, disorganized thinking and speech disorganized thinking is a typical inferred from individual speech. The individual may switch from one topic to another, such as derailment or loose associations. The answers to questions may be obliquely related or completely unrelated. Rarely, speech may be so severely disorganized that it is nearly incomprehensible and resembles receptive aphasia in its disorganization, such as incoherence or word salad. Because mildly disorganized speech is common and nonspecific, the symptoms must be severe enough to substantially impair effective communication. The severity of the impairment may be difficult to evaluate if the person making the diagnosis comes from a different linguistic background than that of the person being examined. Less severe disorganized thinking or speech may occur during the prodromal or residual periods of schizophrenia. Then there's grossly disorganized or abnormal motor behavior, which includes catatonia. Grossly disorganized or abnormal motor behavior may manifest itself in various ways, ranging from childlike silliness to unpredictable agitation. Problems may be noted in any form of goal-oriented behavior, leading to difficulties in performing activities of daily living. Catatonic behavior is a marked decrease in reactivity to the environment. It ranges from resistance to instructions, to maintaining a rigid, inappropriate, or bizarre posture, to a complete lack of verbal and motor responses such as mutism or stupor. It can also include purposeless and excessive motor activity without obvious cause. It's called catatonic excitement. Other features are repeated stereotyped movements, staring, grimacing, mutism, and speech echoing. Although catatonia has historically been associated with schizophrenia, catatonic symptoms are nonspecific and may occur in other mental disorders such as bipolar or depressive disorders with catatonia, and medical conditions, autism, autoimmune, and degenerative brain disease. Then we have negative symptoms. Negative symptoms account for a substantial portion of the morbidity associated with schizophrenia, but are less prominent in other psychotic disorders. Two negative symptoms are particularly prominent in schizophrenia: diminished emotional expression and avolition. Diminished emotional expression includes reductions in the expression of emotions in the face, eye contact, intonation of speech, and movements of the hand, head, and face that normally give an emotional emphasis to speech. Avolition is a decrease in motivated, self-initiated, purposeful activities. The individual may sit for long periods of time and show little interest in participating in work or social activities. Other negative symptoms include alagogia, anhedonia, and asociality. Alogia is manifested by diminished speech output. Anhedonia is the decreased ability to experience pleasure from positive stimulus or humiliation in the recollection of pleasurable previously experienced. Asociality refers to the apparent lack of interest in social interactions and may be associated with avolition, but it can also be a manifestation of a lack of motivation to engage in social activities. Finally, the diagnosis of schizophrenia spectrum disorder requires the exclusion of other conditions that may give rise to psychosis. Schizotypical personality disorder is considered within the schizophrenia spectrum. The diagnosis of schizotypical personality disorder captures a pervasive pattern of social and interpersonal deficits, including reduced capacity for close relationships, cognitive or perceptual distortions, and egocentricities of behavior, usually beginning by early adulthood, but in some cases first appearing in childhood and adolescence. Abnormalities of belief, thinking, and perception are below the threshold for the diagnosis of a psychotic disorder. Two conditions are defined by abnormalities limited to one domain of psychosis: delusions or catatonia. Delusional disorder is characterized by at least 1 month of delusions but no psychotic symptoms. Catatonia is a brief psychotic disorder that lasts more than 1 day and ends in a month. Schizophreniform disorder is characterized by a symptomatic presentation equivalent to that of schizophrenia except for its duration, which is less than 6 months, and the absence of a requirement for a decline in function. Schizophrenia lasts for at least 6 months and includes at least 1 month of active phase symptoms. In schizoaffective disorder, a mood episode and the active phase symptoms of schizophrenia occur together and are preceded or followed by at least 2 weeks of delusions or hallucinations without prominent mood symptoms. We also have substance and medication-induced psychotic disorders. The psychotic symptoms are judged to be physiological consequence of a drug of abuse, a medication, or toxin exposure, and cease and removal of the agent. In psychotic disorders due to another medical condition, the psychotic symptoms are judged to be a direct physiological consequence of another medical condition. Catatonia can occur in several disorders, including neurodevelopment, psychotic, bipolar, depressive, and other mental disorders.
In the treatment of schizophrenia, chlorpromazine and other first-generation antipsychotics were initially used to reduce positive symptoms such as hallucinations and delusions. However, these drugs were associated with notable side effects such as Parkinsonism and tardive dyskinesia. Second-generation atypical antipsychotics were then developed, showing superior effectiveness in reducing both positive and negative symptoms and having lower rates of neurological side effects. Atypical antipsychotics have activity at multiple receptor sites, including serotonin and dopamine receptors, leading to decreased risk of side effects. However, they can still cause metabolic abnormalities and weight gain. In addition to medication, psychosocial therapy, such as cognitive behavioral therapy, can help individuals cope with and manage symptoms of schizophrenia, as well as encourage adherence to medication.
Our case study focuses on an individual we will refer to as John. John is a 26-year-old African-American male who presented to the emergency department 2 years ago at age 24 after he was arrested by local police for trespassing in his neighbor's yard and throwing trash over her fence. John was overheard yelling that his neighbor and the others were trying to poison him. He also claimed his neighbor had set up recording devices in his bedroom and was trying to read his mind. Before the incident with his neighbor, John was enrolled in a master's degree program in business administration at the state university. Friends and family members noticed something was off when John stopped attending his classes. He began isolating himself and would stay at home for several days on end, refusing to come out and not answering calls from his concerned loved ones. He also began covering the windows in his home with paper, which his parents discovered after visiting him. During this visit, John was observed muttering nonsensical things to himself and refused to engage in conversation with them. It also appeared he had stopped bathing or grooming himself and had lost a significant amount of weight due to his belief that his food was unsafe to eat. After the incident with his neighbor, police escorted him to the ER, where he was evaluated and subsequently transferred to an inpatient psychiatric crisis unit for close observation, where he remained for 2 weeks. John was ultimately diagnosed with schizophrenia, and he was prescribed daily oral Risperdal, which is an atypical antipsychotic medication. In addition to the medication, John was provided with an outside therapist and began cognitive behavioral therapy every week. A mental health case manager was assigned to him and conducted frequent check-ins with him at his parents' home. His parents were extremely supportive and provided John with other means of care, such as visits from extended family members and outside trips in the community to ensure he did not continue isolating himself. He also joined an online support group for individuals with mental illness and began a daily exercise regimen. John remained on the Risperdal for 2 years, but ultimately stopped taking it as he deemed himself cured and did not believe he needed it anymore. Leading up to this, he had gained weight and was constantly sleeping, unfortunate but common side effects of the medication. His paranoia and delusions began to reappear, and he was briefly hospitalized for medication management, which he ultimately agreed to. John is now on a long-term injectable medication, extended-release aripiprazole, which he receives at a psychiatrist's office each month. This is also an atypical antipsychotic medication. John now lives with his parents and has started to attend school again. Continuing with therapy and having the close support of his family and dedicated healthcare team have helped John as he learns to live with schizophrenia. Despite ongoing challenges, John has shown some improvement in managing his symptoms and daily functioning with the support of his treatment team and family. However, his long-term prognosis will require ongoing care and assistance. This concludes our group's presentation on schizophrenia. While stigma remains, improvements have been made in spreading awareness and dispelling preconceived incorrect notions regarding this disease. As healthcare providers, we must do no harm and help to bring a better understanding to schizophrenia and mental health disorders in general. Thank you again for watching.